Good morning, everyone. Hope you're all well. In today's class, we are going to discuss deep dissection of the neck. Now, what do you mean by deep dissection of the neck? Structures which are undercover of the muscular wrapping of the neck, which we've already seen. So we've done the various triangles. We've talked about the posterior triangle, the anterior triangle. We've seen the muscles of the muscular triangle. We've done the muscles of the sternocleidomastoid, the trapezius. Now we are going deeper. That is structures which are deep to this muscular facial wrapping. And by that, I mean, we're going to be talking about the glands which are present in the neck. We're going to be talking about the various tubes. That is the beginning of the gastrointestinal system, the beginning of the respiratory system, and that is the pharynx, the larynx, and all these structures are now the focus of the next few classes. So as you can understand, it's a very broad topic. In this particular class, there are a number of competencies to be covered, but we will be focusing on two competencies, that is thyroid gland and the cranial nerve 10th, that is vagus. So we will describe and demonstrate the location, parts, borders, surfaces, relations, and blood supply of thyroid gland. And we will describe the course and branches of the 10th nerve in the neck. A 55-year-old world-renowned singer goes to the physician with the complaints of a swelling in the neck. When the physician asks her for any other complaints, she has no other complaint except for this swelling which is present in her neck. On examination, he sees a non-tender mass in the neck which is present in the lower part of the neck. He asks the patient to swallow. When the physician asks the patient to swallow, he notices that this swelling moves upward on swallowing. The patient is operated after the usual investigations and all cleared up. The patient is operated. Post-operatively, the patient is fine, but she comes back 2 weeks later with complaints of hoarseness of the voice. So number one, what is the swelling? Why did it move? And number three, why did the patient come back with a totally unrelated complaint of hoarseness of voice? So that is what we need to understand with the help of this particular lecture. The thyroid gland is the largest endocrine gland in the body. You're well aware of the fact that it is the only gland which produces as well as stores its endocrine secretion, which is the thyroid hormone. And to prepare this secretion, it requires raw materials from outside, that is iodine. This secretion, that is the thyroid hormone, it releases whenever there is a requirement by the body. So till then, it is stored in the gland, and whenever the requirement is there, it is released. It is a highly vascular structure, a brownish red color structure, which is present in the lower part of the neck, wrapping around the trachea. So let's draw the structures which are present in the midline of the neck. Please draw with me. If we talk about the midline of the neck, this is the lower border of the mandible. When we were drawing our diagrams of the anterior triangle, we usually make it from there. But right now, since we are bothered only with the thyroid gland, we will draw from the hyoid bone. This is the hyoid bone. This is the thyroid cartilage. You can see the cricoid cartilage and then the tracheal rings. So let's start. The greater cornu of the hyoid bone, the lesser cornu, the body. Lesser cornu, the greater cornu of the hyoid bone, and then we've drawn the body of the hyoid. Thereafter, the superior horn of the thyroid cartilage, the superior border, it joins its opposite partner at the angle, superior angle, and then there is the superior horn of the other side. The laminas, and then we have the focus. The cricoid cartilage, and then you have to understand that in between the hyoid bone and the thyroid cartilage is present a membrane, the thyrohyoid membrane. I'm not doing the attachments. We'll do that when we talk about larynx, right? And in between the cricoid cartilage and the thyroid is a muscle, the cricothyroid muscle. On both the sides. Thereafter, let's draw the tracheal rings. The first tracheal ring, the second, third, fourth, and then I'm going to draw the fifth tracheal ring and the sixth tracheal ring. Thereafter is the suprasternal notch. So and this would be its clavicular fossa. And then comes the first target. So this is the manubrium. So vertebral levels, you know that the hyoid bone is at the level of C3. The superior lamina or the superior border of the thyroid cartilage is at the level of cervical vertebra 4. Here would be the oblique lines of the thyroid cartilage, and the cricoid cartilage is at level C6. Now, the thyroid gland, as you can see in this picture, consists of two lobes and a structure which is connecting these two lobes called the isthmus. So let's draw. Since it's a brownish red vascular structure, I'll just stick to that color. The thyroid gland has two lobes and a connecting isthmus. And by looking at this diagram, where we've put in the vertebral levels, we can say that it extends from the vertebral level C5, that is the fifth cervical vertebra, to T1. As you know, the suprasternal notch is at the lower border T2 and upper border and intervertebral disc between T2 T3. So from the C5 cervical vertebra to the first thoracic vertebra is the extent of the thyroid gland. The other way to put it is that it extends from the oblique line of the thyroid cartilage to the fifth or the sixth tracheal ring. You can also make out that the isthmus is present in front of the second, the third, and the fourth tracheal rings. So this butterfly-shaped gland, which is present in the lower part of the neck, is wrapped around the trachea. That's the other thing which we understand about its location from this diagram. Now, sometimes on the left side, more commonly on the left side, there may be a pyramidal lobe which may be present. So this here would be the pyramidal, in some individuals, not all, lobe of the thyroid gland. And extending from the left side towards the body, mostly from the left side of the thyroid gland, towards the body of the hyoid bone, there may be a fibromuscular structure in some individuals, not in all. A fibromuscular structure which is known as levator glandular thyroid. All right. So we have the thyroid gland, which is present. Its parts, we've understood that it has lobes. It has two lobes and an isthmus, and we've also done its extent. In some individuals, apart from the usual thyroid gland, we may have ectopic thyroid tissue. That is, tissue which is not present, thyroid tissue which is not present in its usual location. That is in the tongue, in the in front of the hyoid bone, in front of the thyroid cartilage, and as pyramidal lobe we just discussed. Or it may be even present behind the sternum when it is known as retrosternal. What is the embryological basis of this? We will be discussing when we do embryology, but they may be other thyroid tissue apart from the thyroid gland, which we've discussed sometimes in certain individuals. So when we study the thyroid gland, we have to look at it in two views. One was in totality, how we saw as a structure, as a whole organ when it is present in the midline of the neck. The other way where we like to study is to understand it in detail is the transverse section. So you're aware that you've already made a transverse section of the neck when you were studying the cervical fascia. Remember when you studied about the investing layer, the pretracheal layer, the prevertebral layer, we're going to draw the same diagram, but we're going to draw only the anterior part of it. We're not focusing so much on the muscles at the back of the posterior triangle, the floor of the posterior triangle, because we are bothered about the visceral component which is present in this particular diagram. So this we are doing presently to understand the capsule of the thyroid gland. So the gland, like any other gland in the body, is surrounded by a capsule. But the composition of this capsule is very different from what we see in the other glands. Here, the capsule of the thyroid gland is made up of two layers, a true capsule and a false capsule. What do I mean by that? Let's understand. So let's start first by making the transverse section. Now in the transverse section, let's make the body of the vertebra. So posteriorly, somewhere here would be the body of the vertebra. I'm just bothered with the body only to make you understand the orientation. So this is the posterior aspect and out here would be the anterior aspect. Anterior to it is present the esophagus, or the lower part of the pharynx and the beginning of the esophagus, because we are somewhere at the C6 cervical vertebra. More anteriorly is the beginning of the trachea, the area of the cricoid, and the ending of the cricoid. So first tracheal ring and the upper part of the cricoid cartilage would be somewhere here. Anterior to it and wrapped around it is the gland in question, the thyroid gland in discussion. This is its lobe, the isthmus, and the opposite side lobe. So these are our visceral structures of importance. This is the thyroid gland. Oops. Should not make double lines. And this would be the thyroid gland. All right. So with its lobes and the isthmus. Now, if you remember, posterior lateral to it is present the carotid sheath. I'm just making you revise the diagram which you've done already of the placement of structures in the neck. So here would be the internal jugular vein, the carotid, the internal carotid artery, and out here would be the vagus, right? More superficially would be the muscles. So we would have the sternocleidomastoid out here, and then we have the muscles out here, which are the sternohyoid, which are forming the part of the triangle, and and the omohyoid would be here, superior belly of omohyoid, the sternohyoid, and this would be the sternothyroid. Similarly, on the opposite side, the same muscles. If we were to draw the fascia, then if you remember, the sternocleidomastoid was invested by the investing layer of the deep cervical fascia. Now, from the inner aspect of the investing layer of the deep cervical fascia arose a layer which was known as the pretracheal layer. The pretracheal layer formed the anterior part of the carotid sheath, reached the thyroid gland, and again split into two layers. One which wrapped around the thyroid gland from both sides, anteriorly and posteriorly. It enclosed it. But the posterior lamina of this particular fascia was not so well developed, but the anterior lamina was very well developed. This would be coming from this particular side. Also, from at the area, also in the from the posterior medial aspect of the lobes to the cricoid cartilage was present a thickening. Cricoid cartilage was present a thickening of the fascia, which is known as the ligament of Berry. And what we can see in this diagram is the lower end of that particular part. Right? So this would be the ligament of Berry. These are the structures of the thyroid gland, and these are the muscles. What was this? The sternohyoid, the sternothyroid, omohyoid, the sternocleidomastoid. Right? So this is the transverse section, or the amount of transverse section which we need for this particular discussion. Okay, and the fascia which we've drawn is, this is the pretracheal fascia. The slip of the pretracheal fascia which is coming in. So the thyroid gland is wrapped by this layer of fascia, the investing layer, by this layer of deep cervical fascia, which is the pretracheal fascia. Now, let's come back to the capsule. The capsule of the thyroid glands are true as well as false. The true capsule is formed by the condensation of the stroma of the gland. So this would be its true capsule, which is formed by the condensation of the stroma, which is of the gland. So the condensation of the stroma, the connective tissue of the gland, will form the true capsule. The other layer is the false capsule, which is formed by the part of the pretracheal fascia, the part of the pretracheal fascia which is wrapping around the thyroid gland. This is the false capsule. So the gland is enclosed by two. On the inner side, there is the true capsule, which is the condensation of the stroma of the thyroid gland. And on the outside is the false capsule, which is formed by the pretracheal layer of the cervical fascia. The false capsule, and this would be the true capsule of the gland. There is a space which is present between the true and the false capsule, which is occupied by the parathyroid glands posteriorly. Also present between the two are the blood vessels which are piercing this capsule. This is the superior thyroid artery, which is going to be piercing these capsules to supply the gland. So the blood vessels, the arteries are present, which pierce the gland and then go into pierce the capsule and then the gland to supply the gland. All right. Then another thing which we need to see is that this fascia, this is what we have discussed out here is the transverse or the horizontal description of the deep cervical fascia, or the horizontal layout of this particular fascia. But there is also a vertical extent to it, which you already see. So vertically, if we were to see this layer, so let me pick up green. This false capsule goes above and gets attached above to two areas. Number one, to the oblique line of thyroid cartilage on the side and to the hyoid bone in the midline. So ये जो fascia, ये जो false pretracheal fascia, जो false capsule बना रही है, वो not only gland को invest कर रही है, but ऊपर जाके vertically when we trace it upwards, it goes and gets attached to the oblique line of the thyroid cartilage. That is, this part of it would be going and getting attached to the oblique line, and there is also a part of it in the midline which is going to the hyoid bone. Now the thyroid cartilage, the hyoid bone are forming the skeleton of the larynx. Every time you swallow, the pharynx moves and the larynx also moves. Now when the larynx moves, because of this attachment of the false capsule of the thyroid gland, because the false capsule is derived from the pretracheal fascia, and this pretracheal fascia is attached to the hyoid bone and to the thyroid cartilage, and also there is a thickening of this pretracheal fascia which is getting attached to the cricoid cartilage, which is known as the ligament of Berry. So every time the laryngeal skeleton moves, the thyroid swelling also moves. So our physician, when he wanted to determine that what is the structure which is forming this particular swelling in our singer's neck, he asked the patient to swallow. And when the patient swallowed, the swelling moved upwards. That is one of the characteristic features of the swellings of the thyroid gland. That is, the swellings of the thyroid gland tend to move upwards on swallowing, right? If these swellings are very large, you have also seen that on the posterior aspect, the fascia is not so well developed. So these swellings, when they enlarge, they tend to move backwards. And when they move backwards, when they enlarge backwards, they tend to enlarge more backwards as compared to forwards, because posteriorly, the posterior lamina of this capsule is not very well defined. So this will tend to compress on the airway. As a result, the patient may complain of difficulty in breathing or dyspnea, because the swellings of the thyroid gland tend to protrude backwards or posteriorly and compress, number one, the trachea. If they compress the trachea, it would result in dyspnea or difficulty in breathing. Very large swellings may even compress esophagus, and the patient may complain, apart from compressing the trachea, and the patient may also complain of difficulty in swallowing, and this is known as dysphagia. Okay, now let's see the parts of the gland in detail. Number one, as we've already seen, this is the lobe and this is the isthmus. The parts of the lobe are the apex, base. This surface which you see out here is the anterior lateral or the superficial surface. Anterior lateral or the superficial surface. So if we were to see the same in the transverse section, this would be the anterior lateral surface of the lobe. This would be the isthmus, which is in front of the trachea, but this part would be the anterior lateral surface of the lobe. This surface out here would be the posterior lateral surface, and this surface, which is facing the trachea, is the medial surface. So, the anterior lateral or the superficial surface, the anterior lateral or the superficial surface in the transverse section, the posterior lateral surface, and this is the medial surface. The medial surface. Yeah, one more thing. When you draw the diagram, the transverse section, I made a mistake. Kindly correct it, please, in your diagram. The vertebra which I made in the previous slide was more like a thoracic vertebra. But we are in the cervical area. We are still drawing the C6 cervical vertebra. So this is how a cervical vertebra looks like. In the body, the transverse diameter is more than the anterior posterior diameter. Then it has a foramen transversorium. This is the anterior root. Here would be the tubercle, the posterior root, and then the tubercle, and then would be the costotransverse process, and this is the biped spine. Kindly please make the correction in your diagram. Okay, back to the surfaces. So, this is the anterior lateral surface of the lobe. And this is the posterior lateral surface. Okay, now come to the borders. The borders always separate the surfaces. So this out here is the anterior border. The anterior border separates the anterior lateral surface from the medial surface, which is facing towards the laryngeal cartilages and the trachea. This is the posterior border, which separates the posterior lateral surface from the medial surface. So here is the posterior border. The anterior lateral surface almost merges with the posterior lateral surfaces, but when we study the relations, they are two separate parts. So this is the superficial or anterior lateral, posterior lateral, the medial surface. We've done the various parts of the gland in detail. Now the same gland, if I was to look at it from the posterior aspect. So this here is the laryngeal framework and the tracheal framework. Behind the larynx is the pharynx and the esophagus. So how would that look like? So if I was to look at it from posterior aspect, this would be the constrictor muscle of the pharynx, the inferior pharynx. Inferior constrictor, sorry, the inferior constrictor. You'll study it in detail when we do the pharynx. This is how it would look like. And on both sides of it, again, let's draw the gland here. This is the posterior lateral surface of the gland which we are seeing. Related to the gland would be the superior thyroid and the inferior thyroid gland. So this is the posterior view of the lobes. This is how the lobes would look at when we were to look at the posteriorly. In front of this pharynx out here, in front of the pharynx would be the larynx. So this is the posterior view. These are the superior and inferior parathyroid glands. This is the pharynx, and here would be the pharynx has two kinds of muscles which are making it. One are these longitudinal muscles, and this would be the transverse muscle which is present, transversely running, or the constrictor muscles which are present. So this is the inferior constrictor whole as when we are seeing it from the back with its two parts, right? So that's it. This is the coronal section. This is the anterior view of the parts of the gland. Now, to understand the relations of the various parts of the thyroid gland, it is first important to understand what are the blood vessels which are running in its vicinity. So instead of following the conventional mode of studying in which we do the relations and then we come on to the blood supply, I will fast forward to the blood supply, do the blood supply first, and then get back to the relations of the thyroid gland. The thyroid gland, as you've seen in the transverse section at the C6 cervical vertebra, overlaps the carotid sheath and its contents, right? In the carotid sheath is present the internal jugular vein, the carotid arterial system, as well as the vagus in the neck. So what their branches are in close contact and are in relation to the thyroid gland. So let's see how. Now, let's go on to the beginning of the carotid or the arterial system. The arteries which are going to supply the head and neck arise from the arch of aorta. So let's draw the arch of aorta in the superior mediastinum, where it was related to the sternal angle, and its projection onto the manubrium we saw as the ascending aorta, which was starting at the level of the sternal angle, and the descending aorta, which was also and the end of the the termination of the ascending aorta at the level of the sternal angle and the beginning of the descending aorta at the level of the sternal angle. This arch was present with relation to the lower part of the manubrium. It gave rise to the brachiocephalic trunk for the right side and the left common carotid and the left subclavian for the left side. So I'm going to draw the blood vessels on the right side. So let's pick up the brachiocephalic trunk. The brachiocephalic trunk divides into the subclavian artery, which runs on the subclavian groove, enters subclavian groove on the first rib and then enters into the axilla. Oops. The common carotid, which is running posterior lateral in close contact, but I'm not going to draw it in such close contact because I need space. So this is the carotids. At the level of the upper border, it divides into an external carotid and an internal carotid. This is the internal carotid, which is present more towards the external surface, and the internal carotid, which is present towards the viscera. The external carotid, which is present in relation to the viscera. It gives rise to its first branch, the external carotid artery. So, this is the external carotid artery. It gives rise to its first branch, which descends, which is identified in the neck by the fact that it is descending towards, just leave it out here, well, it's dividing into its rest of its branches, which is identified by the fact that it descends towards the thyroid gland in the neck. It gives rise to an infrahyoid branch for the sternocleidomastoid. It gives rise to a superior laryngeal artery, which pierces the thyrohyoid membrane to supply the larynx, and then pierces the capsule of the thyroid gland, both the falls and the true, and then divides at its apex into two branches, an anterior and a posterior branch, which runs along the posterior border. The anterior branch runs onto the anterior border and ends by anastomosing with the opposite anterior branch at the upper border of the isthmus. So this is the superior thyroid artery. The key thing to remember is that it divides into branches after it's pierced the pretracheal fascia and the capsule and closer to the apex of the gland into its two branches. The anterior branch, which we just saw, this is the anterior branch of the superior thyroid, and running along the posterior, this was the posterior view, is the posterior branch, which anastomoses with a branch from the inferior thyroid artery. So this is the posterior branch of superior thyroid artery. From the first part of the subclavian artery arises the thyrocervical trunk. And from this thyrocervical trunk arises the inferior thyroid artery. This runs behind the carotids. It arches and loops behind the carotid to reach the base of the gland, the thyroid gland, before it pierces the pretracheal fascia and the capsule of the gland. Before it pierces the pretracheal fascia and the capsule of its gland, it divides into a superior ascending and an inferior branch before it has pierced the pretracheal fascia. So it comes out here, divides into its branches, which is a superior ascending, which anastomoses with the posterior branch of the superior thyroid, and an inferior branch. And this it has done before it's divided into its branches. So this is the inferior thyroid artery and its two branches. This is the posterior view. All right. So, at the posterior border, we have the anastomosis, which is present between the superior thyroid artery and the inferior thyroid artery. And at the isthmus, this anterior branch of the superior thyroid artery, anastomosis with that of its opposite friend. So, the blood supply, the main arteries which are supplying the thyroid gland are the superior thyroid artery and the inferior thyroid artery, which is the branch of the subclavian artery, which in turn is a branch of, which is a branch of the thyrocervical trunk, which is in turn a branch of the subclavian artery. When we talk about the venous drain, there is another blood vessel which may be supplying the thyroid artery in some individuals. So it needs to be remembered when we are doing surgery so that we do not miss it out, is the arteria thyroidema, which may arise from the arch of aorta and is a midline structure. In some individuals, this may be present. This is the arteria thyroidema. In some individuals, it may be present. There may be certain other accessory blood vessels also. But the main branches are the superior thyroid artery and the inferior thyroid artery. The venous drainage. Obviously, the internal jugular veins is going to be the one which is the ultimate destination for most of the blood vessels. So let's draw the internal jugular vein, which is also present posterior lateral to the gland in the carotid sheath. And it is in the carotid sheath, it is present more superficial to the carotids. So on the opposite side, let's draw that. Now it's gone really off tangent, but I need that space again. It joins the root of the neck, the subclavian vein and forms the, so let's just draw it, and it forms the left brachiocephalic vein on this side, which will join the right brachiocephalic, which will be coming from this side, right? So let's label the parts. This is going to be the internal jugular vein. This is the subclavian vein. This is the left brachiocephalic vein. All right. थोड़ा यहाँ पर इस एरिया में गड़बड़ हो गया, प्लीज जब आप ड्रॉ करोगे तो थोड़ा सीधा सीधा ड्रॉ कर देंगे. Now, the superior thyroid vein arises at the apex, runs along with the artery. It may enter, crosses over the carotid sheath and enter into the internal jugular vein as a separate blood vessel, or joins the facial vein and then enters into the internal jugular vein. Then there is a middle thyroid vein. So this is the superior, that was the superior jugular vein. This is the middle thyroid vein, which does not have an arterial counterpart. It drains the lower part of the gland and drains into the internal jugular vein. The inferior thyroid vein may be either one here for each lobe, or from the both sides, the veins will join together to form a single midline structure which enters into the left brachiocephalic vein. So these midline structures are especially important during surgery as well as tracheostomy, as we will see in a while. So this is the superior thyroid vein. The middle thyroid vein. And this is the inferior thyroid vein, which enters into the brachiocephalic. Inferior thyroid veins, which enter into the brachiocephalics, which need to be remembered. Also, another vein which you need to remember is the vein of Kocher, which may be present occasionally, again arising from the lower pole. Need to be remembered during surgeries because it may bleed if the surgeon forgets to look for it. Okay. Then let's come on to the veins. That is the nerve, the vagus, which is running in close proximity. The vagus, we'll do in detail in a while. From its inferior ganglion, this is the vagus, which is running in the posterior part of the carotid sheath, gives rise to the superior laryngeal nerve. This superior laryngeal nerve divides into an internal laryngeal nerve, which pierces the thyrohyoid sheath, and a superior and an external laryngeal nerve. This is its superior laryngeal nerve. This is the vagus. This is the internal laryngeal nerve, and this out here will be the external laryngeal nerve. You can see that the external laryngeal nerve is running along with the superior thyroid artery. But near the apex of the gland, it separates from the gland, runs posterior to the apex, to go and supply the cricothyroid muscle, which is a muscle of the larynx, which is important for tensing the vocal cords. So it runs with the superior thyroid artery, but near the apex, while the artery pierces the pretracheal fascia and starts running anterior to the near the apex, it goes anterior to the gland. This particular nerve, that is the external laryngeal nerve, runs posterior to the apex and then runs behind and enters to supply the cricothyroid muscle, which was present between the cricoid cartilage and the thyroid cartilage. The remaining trunk of the vagus, or the main trunk of the vagus, is running in the carotid sheath at the root of the neck on the right side and in the superior mediastinum on the left side. It gives rise to a recurrent laryngeal nerve which curves around either the right subclavian artery on the right side or the arch of aorta on the left side, enters into the tracheo-esophageal groove and ends by supplying the pharynx and the trachea. Now, when it is going towards the thyroid gland, it comes in close relationship with the inferior thyroid artery. If you remember, the inferior thyroid artery first divided into branches and then pierced the pretracheal fascia. So here, in many individuals, it may run in between the branches of the inferior thyroid artery. So the arteries of the thyroid gland are in close relationship with two branches of the vagus. Now, these branches have no role, we don't know what is the role of the parasympathetic supply when it is supplying the thyroid gland. When these branches, when they give their small branches to the thyroid gland, what is its role? We don't know. Because the thyroid gland, is endocrine gland, which is under hormonal control. So its secretions come under the hormonal control. Its blood vessels constrict or dilate depending upon the sympathetic supply which is coming to it. So what is the role of these parasympathetic nerves or branches of the vagus which are running in proximity to it? We do not know. But yes, there are two important branches of the vagus which are ultimately going to supply the larynx and the pharynx. That is the external laryngeal nerve as well as the recurrent laryngeal nerve, which are running in close contact to the thyroid gland and its branches. And they have an important bearing when surgeries of the thyroid gland are being done. Now, before we go on to do the relations, let's finish the lymphatic drainage also. The lymphatic drainage of the thyroid gland goes to the prelaryngeal, the pretracheal, as well as the paratracheal lymph nodes. And from here, it goes on to the deep cervical group of lymph nodes. Please label it. I don't have space to label it in my diagram. So we have the prelaryngeal, pretracheal, the paratracheal group of lymph nodes, and from here it goes to the deep cervical lymph nodes. Again, of importance when we talk about the carcinomas of the thyroid gland. So in this picture, this is being taken just to show you this the view of the thyroid gland from the side. We've been looking at it from the anterior view. So from the side, because most of the neck we studied the lateral view or from the side. So let's just see. This is the lobe of the thyroid gland. This is the isthmus. These are the laryngeal. This is the laryngeal skeleton. This is the cricothyroid muscle. Okay, now this is the carotid sheath contents. You can see the internal jugular vein. You can see the carotid, right? You can see the common carotid and the vagus, which is running posterior to it in this particular area. Now, from here, it would have divided at the level of the upper border of the thyroid cartilage into an external and internal. The external gives rise to the superior thyroid artery, the external carotid. It gives rise to branches which supply the larynx. The superior thyroid artery gives superior laryngeal artery, which supplies the larynx. It also gives rise to the branches to supply the sternocleidomastoid, and then near the apex of the thyroid gland, it pierces the pretracheal fascia, the capsule of the thyroid gland, and then divides into branches. The anterior branch, which runs along the anterior border, and it meets its opposite at the isthmus, and the posterior, which runs along the posterior border to anastomose with the inferior thyroid artery. So it's a highly vascular gland. Then you can see posterior to the carotids is running the inferior thyroid artery, which is arisen from the thyrocervical trunk. And notice out here, it's divided into its branches. And then in between the branches and in close approximation to it is the recurrent laryngeal nerve, which is running, which we need to remember. And यहाँ पर ये external laryngeal है at the upper border, और external laryngeal देखो कैसे दूर होती जा रही है, वो deep जा रही है क्योंकि उसको cricothyroid को supply करना है. But यहाँ पर the blood vessel, the inferior thyroid and the recurrent laryngeal nerve are in close contact with each other near the gland. Okay. This is the sympathetic trunk, which is also running along with the gland, and this will give rise to various branches from the superior, middle, and the inferior cervical ganglions, which will be running with the superior thyroid and the inferior thyroid arteries to give rise to the sympathetic supply to supply the blood vessels. All right, so this is when we look at it from the side view. And this again is the posterior view. This is the posterior leaf. Posterior to the larynx is the pharynx. These are the constrictor muscles of the pharynx, the superior constrictor, the middle constrictor, and the inferior constrictor, what we had drawn in our diagram. The inferior constrictor again has longitudinal, it has this circularly running muscles and it has this longitudinally running muscles, which we had drawn, the two different orientations of the muscle. Now here is the posterior view of the lobes of the thyroid gland. What we can see is the lobes. These are the parathyroids, the superior and the inferior parathyroids. Please remember the blood supply to the superior and the inferior parathyroid glands comes from the inferior thyroid artery. Okay? And at the posterior border, the posterior branch of the superior thyroid artery and the ascending branch of the inferior thyroid artery tend to anastomose with each other. This here is the larynx and the trachea thereafter. This is the pharynx and there would be the esophagus, and anterior to it, हम पीछे से देख रहे हैं. So ये more anteriorly is the arch of aorta, and उससे भी आगे हमारे को दिख रहा है the brachiocephalic trunks, which are joining together to form the superior vena, the brachiocephalic veins, which are joining together to form the superior vena cava. To do the relations of the glands, we'll use again the same two diagrams which we've been using till now. One is the anterior view and the other is the cut section of the neck. So I'll just draw the anterior view at a much closer, in a much closer manner so that we can understand the details. Okay, so here's the thyroid cartilage, the superior cornu, the superior border, the inferior cornu. Then this is the cricoid cartilage, the cut section of the cricoid, the cricoid cartilage which is present, and then other tracheal rings. Between the cricoid cartilage as well as the thyroid gland is the cricothyroid muscle. Let's draw the gland. Let's draw the oblique line here first. Let's draw the gland, the apex of the gland, the apex of the gland, the anterior border, the isthmus, the upper surface of the isthmus, and then again the other lobe on the opposite side, and this is the gland of this particular side. So, the apex of the gland is sandwiched between two muscles. There is the inferior constrictor muscle, which is arising from the oblique line of thyroid cartilage and going towards the pharynx. We just saw it in the posterior view. So that muscle arises from the, part of it arises from the oblique line of the thyroid cartilage. And also arising from the oblique line is the sternothyroid muscle. So sandwiched between the inferior constrictor muscle and the sternothyroid muscle is the apex of the gland. Also closing towards the apex, we saw nearing the apex was the superior thyroid artery, which pierced the fascia and divided into an anterior and a posterior branch. This anterior branch went on to form an anastomosis with the anterior branch of the opposite side. So here's the superior thyroid artery. Running in close relation to the superior thyroid artery was the external laryngeal nerve, which is a branch of the superior laryngeal nerve. And at the apex, it went posterior and went on to supply the cricothyroid muscle. So you can see that near the apex of the gland, in close relation to the apex, are two muscles. Number one, the sternothyroid, and number two, the inferior constrictor. Also running is the external laryngeal nerve and the superior thyroid artery. So all these structures are related to the apex of the gland. The base of the gland, to the base is coming the inferior thyroid artery, which divides into its branches and then pierces the pretracheal fascia. And in close proximity, either going in between the branches or anterior or posterior to the branch, these branches is the recurrent laryngeal nerve. So the base of the gland is related to the inferior thyroid artery and the recurrent laryngeal nerve. The anterior lateral surface or the superficial surface is related to the skin, the superficial fascia or the superficial fascia, the investing layer of the deep cervical fascia, sternocleidomastoid to the superior belly of omohyoid, the sternohyoid, and the sternothyroid muscles. All these structures are related to the isthmus as well as the superficial surface of the gland. The posterior lateral surface of the gland is related to the carotid sheath and its contents. The medial surface of the gland. The medial surface of the gland is related to two tubes. The larynx and the pharynx, cranial to C6 cervical vertebra, and the trachea and the esophagus caudal to the C6 cervical vertebra. So two tubes. Then it is also related to two muscles. The cricothyroid muscle and the inferior constrictor muscle. So the cricothyroid muscle and the inferior constrictor, cricothyroid muscle and the inferior constrictor muscle are the two muscles which are related to the medial surface of the gland. Two nerves, the external laryngeal nerve and the recurrent laryngeal nerve are the two nerves which are related to the medial surface, and two cartilages, the thyroid cartilage and the cricoid cartilage. So to the medial surface of the gland are related structures in tubes. What are those? The two tubes, Trachea, larynx, or trachea and larynx, and esophagus and pharynx, depending on which level are we talking. Two muscles, the inferior constrictor muscle as well as the cricothyroid muscle. Two nerves, the external laryngeal nerve and the recurrent laryngeal nerve. The isthmus, on the other hand, anteriorly, again, to the muscles of the muscular triangle, the skin, the superficial fascia, the sternocleidomastoid. The posterior surface to the trachea, right? To trachea or the larynx, depending on, again, what level we are talking. Sorry, it is related to the trachea. Only the tracheal rings, sorry, not the larynx. Only the second, the third, and the fourth tracheal rings, because the isthmus is present only in front of the second, the third, and the fourth tracheal rings. So anteriorly are the muscles of the muscular triangle, the skin and the superficial fascia. Posteriorly is the tracheal rings, which are related to the isthmus. To the upper border of the isthmus is present the anastomosis between the anterior branches of the superior thyroid artery. Also present here would be in some individuals would be the pyramidal lobe as well as the levator glandulae thyroid, which is going up towards the thyroid bone. In certain individuals, the upper border may be also related to this. The lower border is related to the inferior thyroid veins. The lower border of the isthmus is related to the inferior thyroid veins. So all these structures, their placement, you've already seen in the previous slide. Here we're just getting them all together to understand the relations of the various surfaces and borders of the thyroid gland. Using the same diagrams, you can explain the structures. So most of the applied anatomy we've already discussed in parts with the relevant anatomy when we discussed. Again, just to sum up, because a number of times this comes as a part of a long question. So you need to know that while doing applied anatomy, that you would talk about the enlargement of the thyroid gland, which is non-neoplastic as well as non-malignant, which is the goiter, which is due to deficiency of hormone. A very enlarged thyroid gland can cause dyspnea and dysphagia because of the structures which are related to it medially. We've discussed this already. So please explain the reason why. The swellings of thyroid gland move with deglutition. Again, we've discussed it already. Please talk about it. The other thing, during thyroidectomy, there are certain things which one needs to remember. Number one, while performing a thyroidectomy, it is important to remember that the parathyroid glands are related to the posterior surface. Inadvertent removal of the parathyroid glands may result in tetany to the person. That is, deficiency generalized spasms due to low calcium levels. Number one. Now, while removing the thyroid gland, the arteries need to be ligated. One has to ligate the arteries which are running with it. So if you remember, if we were to see the gland, this is the thyroid gland. When we look at the lobe from the lateral aspect, it was surrounded by its own capsule as well as the false capsule. This is the false capsule. These are the thyroid glands which are related, parathyroid glands which are related to it. The superior thyroid artery, which pierces the pretracheal fascia near the apex and then divides into its branches. Okay? And there was one anterior and there was a posterior branch which was running with it. Running along with this was the external laryngeal nerve, which went posterior to the gland to the cricothyroid membrane. So when we are ligating this artery, you can see that the artery and the nerve are in close relationship to each other until they reach the apex. At the apex, the artery enters into the fascia and the nerve goes posterior to it. So at this point in time, when we want to ligate this structure, we have to remember that the artery is ligated close to the gland, because out here, the site of ligation of the superior thyroid artery is close to the gland. Because if you do it away from the gland, at that point in time, you may involve the external laryngeal nerve in your ligation, and as a result, injure the external laryngeal nerve and hence the cricothyroid, and then the patient would complain of hoarseness of voice, like the patient in our beginning of the class, the singer. The singer said that she had difficulty there was a difficulty when she was singing. So it could be because the external laryngeal nerve was damaged while the surgery was being performed. I'm not going to discuss that case in detail. Now that I've discussed the anatomy with you, I want you to discuss it with your table teachers once you get into it. The other case, the inferior thyroid artery. The inferior thyroid artery divided into its branches and then pierced the pretracheal fascia. So the recurrent laryngeal nerve runs in between its branches, anterior to it, posterior to it, or in between. So the site of ligation should be away. It is here where we would like to ligate the inferior thyroid artery. So the site of ligation of the inferior thyroid artery is away from the gland. Also, while performing thyroidectomy, the surgeon needs to remember that the inferior thyroid veins as well as the thyroidema arteries which are running close to it. You also have to remember the presence of the fourth vein, because in case we don't ligate it, it may result in bleeding. So the site of ligation of the arteries is important. Then what is important? One has to remember the relation of the parathyroid glands and not remove the parathyroid glands, as well as the other vessels which are running with the gland. The other important thing which comes to applied anatomy of thyroid is tracheostomy. Now, what is tracheostomy? These days, especially in COVID times, a large number of times the airway needs to be established for the patient. Now, when an airway is being established, at that point in time, the doctor tends to make a incision in the trachea and insert an airway. Now, where in the trachea do we need to make this incision? Either in front of the second, third, fourth rings or in front of the first and second rings. Now, in front of the second, third, and fourth rings is present the isthmus of the gland. So that's isthmus of the thyroid gland. So how does the person move up? First, a transverse incision is made in the skin of the neck. The muscles, the strap muscles, are moved laterally. Please remember, we've discussed this also. Why are we moving them laterally? After that comes the isthmus of the thyroid gland. Again here, you need to remember the presence of the inferior thyroid veins as well as the thyroidema artery. Then the isthmus is either moved superiorly or the person goes in the first and the second tracheal rings, goes and makes an incision in the first, second rings. Or अगर second, third, fourth में जाना है तो isthmus को या काटो, either the isthmus is cut or it is retracted superiorly. And then the tracheostomy tube is inserted. So all these points need to be remembered and written when we are talking about the applied anatomy of the thyroid gland. All right. With this, I think we've covered the thyroid gland. The case we will discuss you will discuss with your table teachers, and we will go forward. Now let's come on to the vagus. The vagus is a mixed sensory nerve. That is, it's a mixed nerve. That is, it has both a sensory component, which is going to be supplying, which was carrying the sensations, as well as a motor component. Number one, that is the important thing to remember. It has a long course. You've already seen it in the thorax. We're now going to see it in the neck. Then we will be again studying it in the brain and thereafter even in the abdomen. It arises from the medulla by means of series of rootlets which join together and then exits through the jugular foramen in the neck. So again, let's draw the jugular foramen, and it exits through the intermediate compartment of the jugular foramen. In the posterior most compartment, for our bearings, let's draw certain structures. In the posterior most part, we know is the sigmoid sinus becoming the internal jugular vein. We've already seen that, right? So this is the internal jugular vein. Thereafter, let's draw the blood vessels so that we again have our bearing. This would be the internal carotid artery, which is going into the carotid canal. So this would be the internal carotid artery. And let's draw some branches of the external carotid artery, which is now in the form of branches out here. Right? So these are the external carotid arteries. Now through the intermediate compartment, as we've already done earlier, exits the glossopharyngeal. So let's make the glossopharyngeal, which is exiting, which goes in between the external carotid as well as the internal carotid artery. It goes in between these two and is on its way to the submandibular region to supply the posterior part of the tongue. So that's the glossopharyngeal. We will be studying that in detail later. Then you've already done the accessory, which also comes out through the intermediate compartment and goes towards the posterior triangle. So this is the accessory nerve and this is the glossopharyngeal nerve. Now, in the intermediate compartment, present in the middle is the vagus, which out here forms two ganglia, the superior ganglia and thereafter an inferior ganglia. After this, it has a straightforward course in the neck. You saw it to be a content of the carotid sheath, and it goes all the way down to the root of the neck in a straight manner with no deviations whatsoever. Yes, it would be giving branches, and these are the branches which we would be studying now. Now, the first branch of the vagus, which arises from the superior ganglia. Now, the superior ganglia is nothing. It's a ganglia, collection of neuronal cell bodies. And these cell bodies are those of which are carrying general sensation to various parts of the, to the skin of the various areas of the head and neck. Now, the auricular branch of the vagus, or the somatic structures actually. The auricular branch of the vagus is the branch which arises from the superior ganglia, and it supplies the external acoustic, the skin of the external acoustic meatus, as well as the a part of the tympanic membrane. It enters into the area of the external acoustic meatus through the tympanomastoid fissure. So the first structure is the auricular branch of the vagus. It also gives rise to a meningeal branch, which again goes through the jugular foramen backwards. So it's a recurrent meningeal branch of vagus. From the inferior ganglia arises the pharyngeal. Now these are the visceral, in the inferior ganglia contains collection of cell bodies which may be supplying the viscera or the muscles. The first is the pharyngeal plexus, the pharyngeal branch of vagus, which again moves in between the external and the internal carotid. So if you remember, there are certain structures which were going in between the external carotid artery and the internal carotid artery. That was the parotid. Then there were structures, that is the styloglossus and the stylopharyngeus muscles, which were arising from the styloid process. There was the glossopharyngeal nerve and the pharyngeal branch of the vagus, which is going to the pharynx to form a pharyngeal plexus along with the glossopharyngeal nerve. So it takes part in formation of a pharyngeal plexus. This plexus supplies the soft palate, muscles of the soft palate, and the pharynx, with certain exceptions which you will do when you do these parts. Okay, so muscles of the soft palate and the pharynx are supplied by this pharyngeal branch. And the pharyngeal branch goes in between the external carotid and the internal carotid. The next structure to come is, the next branch is the superior laryngeal nerve, which we saw earlier in the thyroid, which divides into two branches. One is the internal laryngeal nerve and the external laryngeal nerve. So it divides into an internal laryngeal nerve which goes inside the larynx. So it's called internal laryngeal nerve to supply sensory supply to the mucosa of the larynx above the vocal cord. The other is the external laryngeal nerve, which you saw earlier, which was accompanying the superior thyroid artery. This was accompanying the superior thyroid artery and goes on to supply the cricothyroid, which is a tensor of the vocal cords. The internal laryngeal nerve is also accompanied by a blood vessel, which is the superior laryngeal artery, which is a branch of the superior thyroid artery. Right. Thereafter, the vagus enters into the neck. It goes anterior to the subclavian artery on both the left side as well as the right side. And since we are drawing the left side, let's draw in the arch of aorta. So it goes first anterior to the subclavian artery and enters into the thorax. It is behind the brachiocephalic veins, anterior to the subclavian artery. Thereafter, it moves anterior to the arch of aorta. This is the arch of aorta. And on the left side here, it gives rise to the recurrent laryngeal nerve, which goes posteriorly to the arch and enters accompanying having a relation with the inferior thyroid artery, and it enters into the larynx. The recurrent laryngeal nerve, as we've seen earlier, enters into the, as we've talked about a little bit earlier, it enters into the larynx. It supplies the vocal cords, the sensation to the vocal cords. So it supplies, this recurrent laryngeal nerve supplies sensation to the larynx below the vocal cords and motor supply to all the muscles of larynx except cricothyroid. So this is important. So these are the important branches. On the right side, the recurrent laryngeal nerve arches or loops back around the subclavian artery. And you've already done the development of arches and you know why this takes place. This is because of the embryology of this particular area. Right? Because you've done the aortic arches. So now you can correlate the development of the aortic arches with the course of the recurrent laryngeal nerve. Why the course of the recurrent laryngeal nerve differs on the right side as well as on the left side. What disappears on the right side but does not disappear on the left side? Please go back, revise, and that is the reason why there is a difference in the course of the vagus nerve on both sides. I'm not going to tell you that. Please revise that. All right. Now let's discuss what happens if the vagus nerve is injured. Now the vagus nerve has a very long course within the neck. It is in close relation to a number of blood vessels. For example, we saw the external laryngeal nerve was in close relation to the blood vessels which were supplying the thyroid, that is the superior thyroid artery. And then it is in close relation to the common carotid, the internal carotid artery, while it's lying within the sheath. Within the carotid sheath. Within the thorax also, we've seen that it has a long course, which it also exhibits a long course out there. Now, anywhere in its course, it can get injured, and that injury would result in, as we've seen earlier, loss of sensation and motor paralysis of certain muscles. So we need to find out what will happen and how can we test it and come to a conclusion that the vagus is injured. Now, firstly, it's auricular branch. Now, this auricular branch, more than injury, what affects it is irritation. Now, there is a part of the external acoustic meatus as well as the tympanic membrane, which we will do in detail when we go on into the ear, which is supplied by this auricular branch of vagus. Now, during procedures which are involving the external acoustic meatus, this nerve can get irritated, and irritation would initiate certain vagal reflexes. Now, the vagus is supplying the heart, the vagus is supplying the various blood vessels, it's supplying we've seen it'll be supplying the heart, it's supplying the various viscera. So initiation of these reflexes would bring about vomiting, sensations like vomiting, as well as cardiac syncope can take place, cardiac arrest can take place, or even fainting episodes can be taking place because of the initiation of vagal reflexes, in which vagal is an efferent in a number of reflexes, which you will be doing in detail when we do neuroanatomy. Number one. Then comes the other nerve, which is important, which is the superior laryngeal nerve, and that too, the injury to the superior laryngeal nerve would cause loss of sensation in the larynx above the vocal cord if the internal laryngeal nerve component is damaged, or it would result in paralysis of the cricothyroid. More commonly, it is this external laryngeal nerve which gets injured, as was the case in our singer, when it may have got inadvertently injured while the surgeon was tying the superior thyroid artery. The external laryngeal nerve also gets tied. It would result in no hoarseness of voice or any other loss of in general speaking, but yes, when the singer is trying to sing, or when he's going to go to a higher pitch, when the tone is required, that's what gets affected when there is paralysis of the cricothyroid, which happened in our case earlier. Now, within the neck, please also draw two more nerves which are arising from the vagus, which are the cardiac. Which I forgot to make in the previous diagram. So please make it in your diagram previously, are the two cardiac nerves which would be arising at various levels within the vagus. Now, these cardiac, you know that the neck, the heart is residing in the neck for a very brief point in time. So that's when it gets these cardiac branches come from the vagus arise, which innervate the neck. And when the heart descends, these nerves descend with the heart in the neck. Now, the other nerve, which has a long circuitous course with various blood vessels, associations with various blood vessels, is the recurrent laryngeal nerve. Injury to the recurrent laryngeal nerve will again cause loss of sensation of larynx below the vocal cord. Plus, it would cause paralysis of muscles of the vocal cord except the cricothyroid, and would result in hoarseness in voice. The patient will have hoarseness in voice, and depending on if it's a unilateral injury or a bilateral injury, these effects will vary, which again you will study in detail when you go on to labs. So how would you test the vagus nerve? For testing the vagus nerve, you can test it very easily by asking the patient to open his mouth, and then the patient is asked to say ah. Now, if you remember, the vagus was supplying motor. It has a long course, but when we are testing it जहाँ पर वो चीजें supply कर रही है to the area of the head and neck. So when you ask the patient to say ah, now it was supplying the muscles of the soft palate. In case the uvula, this is the structure which is there in the oral cavity, which is known as the uvula, which is a part of the soft palate, and usually it's present in the midline. You've seen it in your own oral cavity. Now, this is usually present in the midline. When the patient says ah, in case the vagus nerve is lesioned, this uvula tends to be asymmetrical in position, and it deviates away from the lesioned side. That is, it deviates towards the normal side when the patient is saying ah. This is in contrast to what we would see when we see the hypoglossal nerve injury. So here, when we ask normally, when the patient says ah, the uvula, when the nerve is intact, the uvula elevates and moves backwards, and it does so symmetrically. In case the vagus nerve is injured, it tends to deviate from its midline position. And where does it deviate? It deviates away from the lesioned side, away from which side the vagus is paralyzed. It deviates towards the normal side. So in this particular case, this is the side where the vagus is injured. Plus, you can also do a laryngoscopy and detect the position of the vocal cords, or we can see for the accumulation of saliva which is present in the pyriform fossa. But again, these things will become clearer to you when we go further within the larynx. So with this, we come to the end of this lecture. Please do your diagrams of the thyroid, as well as the importance and the diagrams of the thyroid, as well as branches of the vagus very well.